Welcome everybody back to our monthly audio-vestibular medicine case discussions. And if you saw the original promos for this case discussion, we were supposed to have a guest speaker, Joel Goebel, who was formerly at Washington University. Unfortunately, he could not make it for some emergency personal circumstances. So we've put together a quick open free-for-all discussion on PPPD that we're going to do today. And next, I just want to go through our disclaimer slide. As I mentioned, my name's Jerry Gianoli. Our other co-hosts are Mohamed, Hamid, and Eugen Ionescu. The purpose of this meeting is strictly for educational purposes and not intended for medical advice for any individual. For medical advice, please seek the counsel of your own physician. While these conferences are geared toward medical professionals, patients are welcome. However, we will not discuss individual patient cases in this setting. Please speak to your own physician for individualized medical care. And lastly, you can see our discussions that are archived on our YouTube website at AVM Case Discussions. All right, and I have a few cases to present. They're going to be quick, and Mohammed's got a few. And anybody wants to jump in with the discussion during this, feel free to stop in and open up. As I mentioned, this is the PPPD free for all because, and I called it this because I find it's one that evokes a lot of passionate discussions on both sides of this particular diagnosis. So the first thing I just thought would be worthwhile putting out here is the Barony paper that came out in 2017 that listed the diagnostic criteria for persistent postural perceptual dizziness, or 3PD or PPPD. And the criteria are listed here, and you must, according to their paper, you must have all 5 of these criteria to make the diagnosis. The first being dizziness or unsteadiness, and specifically non-spinning vertigo for a prolonged period of time. B is the symptoms occur without specific provocation, although they can be worse or better at different times. C is the disorder is often precipitated by other causes of inner ear problems. D is, of course, it must cause significant stress, distress, or functional impairment. And E, of course, the catch-all symptoms are not better accounted for by another disease. Now, one thing that I thought was interesting, I had forgotten about this, but they specifically eliminated anxiety, depression, panic attacks in the diagnostic criteria, which the forerunners of like chronic subjective dizziness and visual vertigo included those things. And personally, I think it's a good thing that they excluded that, but I had forgotten that they had. Any comments about this, guys? Mohamed, Eugene, Art, anybody?
I don't know what they mean by non-spinning vertigo.
Yeah, I think, the whole, if you go into the paper, it talks a lot of this rocking sensation stuff. And I think that's more the description. Patients will describe that in a lot of different ways, rocking like waves, like I'm on a boat,
Swimming,
the mal de Bartman type sensation as well. And I that's what I'm taking from it, Mo.
I think one of the reasons they put it in there is because years ago, I mean, medical students are taught that spinning is vertigo. If you haven't got vertigo, this is in North America, if you haven't got vertigo, if you haven't got spinning, you haven't got vertigo. In Europe and Asia, you can have physiological height vertigo, which is like standing on the 85th floor of an apartment and it bothers you. So they're differentiating that, telling the Americans and or the North Americans, I mean, that you can still have vertigo, but it's not, you can still call it vertigo, that's okay, but it's not spinning. So it's sort of clarifying that. That was my take on it anyway.
Yeah.
And in France, also, there are some colleagues which calls floating or rocking a kind of vertigo, but which would be specific to the autolytic system.
Yes. Yeah.
Yeah,
Yeah.
that's exactly how I explain it to patients, Eugene. I'll tell them the spinning stuff comes from the semicircular canals and the rocking stuff comes from the otoliths.
Yeah.
It's just the way I
I mean,
um,
vertigo is vertigo, really. I
Yeah.
mean, and on a merry-go-round, people relate to that very quickly. But for example, when you have, oh, I'm spinning, but you don't see nystagmus, for example, that becomes a little bit of a challenge to the examiner or examining physician or doctor, I would say.
awesome. I have the next two slides I have are two papers that I thought were kind of interesting to highlight. This first one was put out by the Vanderbilt group, and they looked at 31 patients who had, and these are two groups of patients went through full audiovestibular testing, and they had 31 patients who had isolated unilateral ovemp abnormalities and compared it to a group of 30 some odd patients who had no abnormalities. And the big distinction they found when they looked at the symptoms of these patients was number one, postural instability, and number two, a rocking or swaying sensation. And that was the only two, statistically significant different symptoms between those two groups, which kind of reinforces this is something you're going to see with, it's specifically in their case, a utricular disorder, which I thought was kind of a nice paper to look at. It really suggests, hey, rocking is an otolithic phenomenon. The next paper, and this is not published, this was, and it was written by Lauren Bartels, who I wish was on the discussion panel with us, but he put together just a little paper that was never published. It was just circulated amongst a group of us in a discussion, and it was titled "PPPD is not a diagnosis." And his emphasis was it is just a syndrome of someone who's got an otolithic dysfunction, and which is what we've been talking about. I liked he did a very nice job with this paper, and one thing I liked was he listed here 10 potential causes for PPPD, and it runs the gamut from vestibular neuritis to inflammatory middle ear disease, surgery on the inner ear and stapes, degenerative changes, etc. But I thought it was great in that it's like, okay, these are things that can cause otolithic dysfunction, and consequently, these folks can have problems afterwards. And if I don't feel like I have the authority to be able to distribute this paper to folks, but if you're interested, we can certainly ask Lauren if he minds us passing it around. And then I have a few cases that I thought might be interesting to go through, and they'll be quick. There are three different cases of three different diagnoses that all presented with a PPPD type presentation. And this first one was this 84-year-old lady who came to see me not too long ago, who was quite a character, and asked her, well, ma'am, why are you here? And she said, I'm on a cruise ship and I want to get off. And it's like, excuse me, what? It's like, I feel like I'm on a boat. It's rocking back and forth. It's been going for 5 years. And she was only symptomatic when she was standing or walking. She had no symptoms sitting or lying down. She had 2 or 3 falls and needed a walker to get around because it made her feel unstable. Her exam was essentially unremarkable. I did not do Fukuda or Romberg because she was so unsteady. I did do a video exam of her eyes that showed no spontaneous nystagmus, and her head shake showed a few slight left beats of nystagmus. I didn't do a real full otologic, excuse me, a vestibular workup on her. I did a little bit of a pared down one because she just sounded so otolithic to me. But bottom line was her CVEMP and OVEMPs had no response on either one. Posturography, she free falls on 5 and 6, which strongly implies saccular dysfunction. And then the last one, I was concerned she had elevated intracranial pressure because my tympanic membrane displacement analyzer or Marchbank's device was consistent with that. Um, so got an MRI scan, and on the MRI scan, she had an empty cella and she had CSF encroaching into her optic nerve sheath with dilated optic nerve sheaths. And she also talked about having blurred vision, although the ophthalmologist said her eyes were fine. So I said, ma'am, we're going to do a lumbar puncture. And so we did a lumbar puncture, and opening pressure was 37 centimeters of water. For those of y'all not familiar with the numbers, normal is basically 9 to 18 or 20. Definitely over 25 is high. So 37 is really up there. Surprisingly, it didn't take much release of CSF. We only took 8 cc's out and it dropped it down to 19. But immediately she felt like a brand new woman. She had complete resolution of the rocking. She had clearer vision, first time in 5 years. So I started on Diamox, and that resolved her problem. A couple months later, she has a long history of chronic pancreatitis. There was some concern the Diamox was aggravating it, so she stopped it. Of course, the rocking immediately came back, and then her GI doctor said, "Oh no, the Diamox is not doing this." So we put her back on the Diamox, and she's back to being resolved again. So this is a case where somebody who presents exactly like the criteria that put forth by the Barony Society, and the etiology is elevated intracranial pressure causing otolithic dysfunction. And I didn't present this, but there's other papers showing increasing intracranial pressure causing suppression of the otolithic function. Any comments on this case before I go on?
This sort of unrelated, but an 84-year-old female. Did you check her for osteoporosis? There's been a correlation. I mean, you obviously made your diagnosis. You figured her out. That's great. But in 84-year-old females often have there's a correlation been shown between osteoporosis and otolithic problems. I wonder if she had osteoporosis.
That's a great point. I must admit, though, I didn't check her for that.
Yeah. Well, you fixed her anyway, so you didn't need to.
Yeah.
Well, I would say had a presentation with the being on a boat and wants to get off. That is also typical of MDDS, and some of these patients don't remember their travel history or what have you. Did she have a history of migraine out of curiosity?
No, I specific, especially with the elevated intracranial pressure, like, do you have headaches or anything like that? Nope,
Yeah.
nothing.
And
Wow.
I would have put her on Diamox or Topomax, and probably she would have got better.
Yeah.
Now, but I think I like your thinking about the getting the CSF pressure, obviously, and it's easy to do. I mean, it's something medical students do it during their training. Now, how about CT scan of her temporal bones? Would it be useful?
Yeah, I did that. It was normal.
Oh, okay.
Yeah.
Yeah.
Yeah. So that, I have to admit, I did a few other little tests, but everything was not real impressive
Oh.
compared to what I showed.
Yeah.
Um,
Did,
but
did she did she come to you with the diagnosis of PPPD?
she did not. But I could easily see how she would have been called PPD.
Yes. Yeah.
Uh,
Yeah.
Okay.
because of her
Oh,
presentation. No vertigo at all. She specifically said, I do not have vertigo. Everybody asks me if I have vertigo. I don't have vertigo. I'm just rocking. And it's only when I'm standing up and walking around. She was cantankerous.
Yes. But did she give you a big hug and really thanked you very much?
Oh yeah, at the end,
yeah.
yeah. Oh yeah, she's a happy camper now. She really is.
She-
Yeah.
Listen,
Okay.
these case presentations, wolf in sheep's clothing presentations are so important to have. I mean, that was really good. Of course, she had. You give her take her history. Of course, she's got PPPD. What are you talking about? Well,
Well, I think that's one of the points. It's sort of like if you didn't do any testing or evaluation of this lady, you could easily label her PPPD.
yeah.
She
No,
did
no.
not have the anxiety
Yeah.
like a lot of them talk about, but as I mentioned, that's not part of the criteria now.
Yeah, but she has legitimate symptomatology, and
Oh, she's fine.
I
Yeah.
don't want
Yeah.
to use non-anatomical, non-physiologic, non-pathologic words. Anyway, I'll make a point during my presentation.
So this is the
Good.
second case I have, and it's a bilateral superior canal dehiscence patient who presents with a PPPD type presentation and was actually diagnosed with PPPD.
Who
Uh,
diagnosed him with that, if I may ask?
Gosh, I don't remember.
Okay.
It was a patient from out of state and a physician that I just don't remember. But her complaint, she's 29 years old, chronic rocking sensation. She was mainly symptomatic when walking or standing, but she would also be symptomatic when she was sitting or laying down. Her only other significant trigger was exercise, and she also specifically denied any spinning vertigo. She was sound sensitive in that sounds would hurt and bother her ears, but she specifically denied sound-induced dizziness or vertigo. And on top of that, she had severe, and I'm talking about severe anxiety and panic attacks. Her physical exam was normal, but interestingly, she refused to let me do a head shake because she was worried about it making her feel bad. Um, Her testing, she had normal audiometry. She had bilateral borderline abnormal ECOGs. She came at zero point 0.4, which is our cutoff for abnormal bilaterally. CVEMP thresholds were 85 decibels bilaterally, which are kind of in our office. That's kind of a little bit in the gray zone for
Yeah.
us. OVEMP amplitudes were definitely elevated, definitely abnormal bilaterally. She had an abnormal left fistula test, abnormal left Tulios test. Her video ocular counterroll test, which, as you guys know, is a test of utricular function, seeing how much the eye rotates back when you tilt the head one way or the other, was significantly reduced on the right side by 38% and 35%. She had normal calorics, and her rotational chair study was consistent with an uncompensated vestibular loss. CT scan demonstrated bilateral superior canal dehiscence. MRI scan was unremarkable. I treated her initially with Lexapro because her anxiety was so bad. And that did help with the anxiety. I put her on medical therapy for her superior canal dehiscence, which includes diuresis, dietary avoidance of straining. It failed. She was still quite symptomatic. So we eventually did bilateral sequential superior canal dehiscence surgery, and that resolved her symptoms. That's probably about 4 or 5 years ago we did her surgery. So this is a case I think is interesting that she prints very similar to the other lady, except she had, and I will tell you, I did do an LP on her. It was low normal on her. Um, but she's someone that's got superior canal dehiscence as opposed to elevated intracranial pressure.
Hmm.
That's all I got on this case. Any comments, guys?
Do you have some images in the superior semicircular canals plane and the partial plane. In other words, the surface of the superior semicircular canal dehiscence was big enough to think maybe to an spontaneous autoplugging or partial autoplugging.
Right. Yeah, it was there, but it wasn't that big to make it suspicious for auto plugging. That's a good point, though.
Hmm.
Yeah, because the auto plugging, you could certainly see that would cause some more that rocking sensation.
I mean, the bilaterals are hard to diagnose initially, but once you got the diagnosis, then it's either medical or surgical. The-
How long did you wait between doing her two sides?
I don't remember. My general rule is I wait at least 3 months, but I think in her case it
Yeah.
was closer to, 9 months or a year
Yeah.
between the two.
And did you do the second side because the first side hadn't reduced your symptoms, or because you were going to anyway? You knew she needed both sides done.
In her case, I kind of thought at the
Yeah.
beginning she was going to need both.
Yeah.
But you could tell there was significant benefit from that side because the Tulios, we did the left side first. The Tulios
yeah, yeah.
phenomena went away, or the Tulios testing became normal. And the unilateral symptoms that you can attribute to it kind of went away. Because I bring them back, I repeat their VEMPs, I repeat their pressure fistula test. Repeat their Tulios test. See, okay, was it successful? Do we need to do the other side? And so in her case, the side we fixed all looked good, and we went on to do the other side. I got
Did you
one. I'm sorry. Go ahead.
did you recorded the video head impulse test before and after?
In her case, she did not want us to do the video head impulse.
Okay, no head
Oh,
shaking test also. Okay.
Yeah, it's funny because I was like, okay, what's my video? And it's like, oh, yeah, that's right. She wouldn't let us do it.
Yeah.
She had autophonia. She had
Uh,
also autophonia.
no, she did not. She did not
Okay.
have any autophony or conductive hyperacusis.
This is
The, I'm sorry, did you say something, Eugene?
No, I was wondering because this is recall a case, one of my cases with partial symptoms like in your case. And finally, when I perform an labyrinthine images, I saw that was a start, that was a beginning of a processes of auto-plugging
Yeah,
and built bilaterally. And I recently published that.
yeah, that's a good one. I
Mm.
have one last case, and this I don't have a whole lot. I don't have any follow-up on yet, but this is a fella who came to me with the same thing. Uh, Only symptomatic when he was upright, no symptoms sitting down, no spinning vertigo, just the chronic rocking and really bad balance from it. On top of that, though, things would be much worse when he would have his head extended or flexed extreme or turned to one side or the other. He said that would often cause headaches along with it. I did a full workup on him, and he basically had no O-vamp response, no C-vamp response, and mostly everything else looked pretty normal. I did CT scan of the temporal bones was normal. MRI scan was pretty normal. There was a little hint that maybe he's got increased intracranial pressure. So I did a MRV, which showed a really atretic left venous sinus system. And so it led me to want to do some vascular studies of his neck. And what we found was the right internal jugular vein looked normal all the way down to about the level of the larynx. And you can see right here, it's being squished between the omohyoid and the sternocleidomastoid muscle. Here's that little tiny atretic IJ on the opposite side. And for you guys not used to looking at necks, this is kind of what a normal internal jugular veins look like on the right-hand side there.
Mhm.
You can see this one is just tiny, tiny, and this one's being squished. So this is a guy who's got significant cervical venous outflow obstruction, and this has been published as a cause for this rocking sensation, mal-débarquement, PPPD as a cause, as well as being relieved when you have a muscle lysis preventing the obstruction of the vessel. And this is the guy I'm trying to get him hooked up with a surgeon to take care of that at this point.
Yeah. How long did he have symptoms for?
This guy, it's been going on for about 3 years, I believe.
Um,
Yeah.
any prior CT for comparison?
No, not that I'm aware of. He
Yeah.
had an MRI scan done at the beginning that was unremarkable. And like I said, in on the MRI scan, I kind of scrutinized and said, does he have elevated pressure? And it's like, he had a little, partial empty sella. He had a little bit of widened optic nerve sheaths. Not real dramatic, but it was there. And I even did a lumbar puncture on this fella just to be sure, and it was normal, and it had no effect on his symptoms. But I kind of wonder is he somebody that has intermittent elevated pressure when he compresses that right internal jugular vein?
Hmm.
And I'll be curious to see what happens with him when we get this surgically fixed.
Yeah.
The question in my mind is, okay, so I've got a guy who's got no response on O-vent, no response on C-vent. Maybe this is the cause, but even if we fix it, is that going to change what we see with his otolithic function? And I don't know the answer to that.
I don't either.
Yeah. So that's all the slides that I got today. And I think I'm going to turn things over to Mohamed, who's
Okay.
got some
Let
slides
me,
to
I'm going to
discuss.
send you a request. Oh, there it is. I know. So, all right. Let me get to this. Okay. Thank Jerry. That was a good presentation. So I have two patients to share with you. These patients actually were seen in the last 4 or 5 months. So patient one is 45-year-old male, not male, 6 months history of episodes of imbalance, head swimming, fatigue, poor sleep, no other focal ear or neurological symptoms, seen by his primary care physician, ENT, and got that he had audio-vestibular testing, all is good. And I wanted to get the test results, but it took forever, and I still don't have them. He was diagnosed with 3PD and referred to physical therapy for vestibular rehab, which he did diligently, and no change. So I kind of took the history again. Yes, he has these symptoms, significant work and home stress, and felt comfortable to talk about it, and was wondering actually why these issues were not raised with him before. It's a type A personality, high achiever. He is athletic. He does actually boating and surfing, and doesn't have any medical diseases or anything. So a neurovestibular exam was normal. I did hyperventilation because during the history taking, you can tell if somebody is even hyperventilating. It's positive and replicated, increased his symptoms. And when started to rebreathe, that symptoms completely disappeared. Um, I made the diagnosis of hyperventilation syndrome. He was satisfied. We talked about, I didn't really know what that PPPD is, but at least he was saying, this is what my doctors diagnosed me with. So the treatment, rebreathing and stress management via lifestyle changes. And really, based on what he shared with me, I encourage him to seek a little bit of extra help with the stress that he has been under. Patient 2, 45-year-old female, stable migraine on Topamax, and she had left vestibular neuritis about 9 months ago with good resolution. I didn't have the results of her investigations back then. And again, continues to have 3 months onset of motion intolerance, exercise intolerance as well, and no significant change in the headache status, no other focal, ear, or neuro symptoms. Seen by neuro ENT, had AV testing and MRI. Everything is normal. I don't know what, again, the vestibular testing that was normal in the face of clearly history of vestibular neuritis, typical, textbook. And for physical therapy, vestibular rehab, no change. She's healthy, she exercises regularly, she's a school nurse, no major work or home stress. Exam was normal except for left reduced vestibular response and post-head shake, mostly left eye drift, plus minimum right beating nystagmus. The VSR, though, was over 90 degrees to the left. She had no BPPV. We did calorics, ice calorics, and supine and positional responses, showed minimum left response, eyes prone, no central findings. Talked to her. I offered her the diagnosis, left vestibular decompensation. Whether it's related to migraine, stress, I can say that both are contributing, although her migraine was pretty stable. I offered her gentamicin perfusion. She had 2 injections, improved over a period of 4 to 6 weeks, and back to regular activities. She questioned the PPPD diagnosis, being a nurse, and we spent a little bit of time talking about that. And she was happy with the correct diagnosis and treatment. So, when we talk about PPPD, from day one, I never really was convinced that it is an adequate diagnosis. And certainly, the wordings were a little bit of interest. I mean, which P comes first, the persistent perceptual or the perceptual persistent? All right. These are descriptive words, as we all know. The disconnected words as well, confusing to patients, and they really don't reflect any anatomical, physiologic, or pathologic meaning. I am so surprised that it's been highly popularized to the point that the Barani Society has accepted it as a vestibular diagnosis. Now, really, physicians, we make diagnoses that has anatomical, physiologic, and pathologic foundations, at least that would help us to explain to the patients in an easy way what do they have. This is very critical to me, at least in my practice. I'm sure everybody does that too. I've never actually used PPPD to explain to any patient in my practice. So most patients, honestly, are unable to explain what PPPD really means. And I think most physicians, mostly ENT, I would say, primary care physicians also now are using it, I don't know if they are comfortable making this diagnosis or just, as Jerry said, it's free for all. They want to just label the patient to explain their symptoms. So it's really in patients' and physicians' best interest to steer away from using the PPPD diagnosis in vestibular medicine.
You know,
And I,
Mohammed,
I'm glad I kind of conceived that early on and never used it, never will.
Mohammed, I think, well, you and I have discussed this many times in the past, and one of the problems with our field is we have a lot of diagnoses that are not diagnoses, they're syndromes, and they don't
Okay?
really get to the heart of what's going on. And I go back to the reason for that is the lack of testing and actually investigation as to what's going on. But if I had any influence in the Barony uh, uh, naming of this disorder, I would have said this is otolithic dysfunction syndrome because I think it gets more to the heart of what's going on. And it also eliminates that context of, it's provoking anxiety, panic, etc., which you can get with any inner ear disorder, can provoke that. But it's again, it gets to the heart of, what's the cause? And it's like you said, you looked at this lady who's got diagnosis of 3PD, and you find she's got a really dramatic loss of function on the left side, which is
Mhm.
obviously the cause. And she's got very asymmetric uh, otolithic function, and which she had never accommodated for. And whatever little bit of function was causing problems for her, you were able to eliminate with the gentamicin injection and helped her compensate.
Uh,
And
the syndromes we have uh, can still be easy for patients, easy for physicians to explain, and also easy for patients to accept. Most of the patients that I spoke with that 3PD diagnosis really were frustrated. They said, we don't know what that is. I don't know what Gene,
yeah,
what's your experience?
Um, I don't know, Matt. I would like to, before I express some thoughts about it, I would like to make a comment on the first time for the first case of Jerry, because that old lady, finally, if you look after, we can put the diagnosis of idiopathic intracranial hypertension. And being an older patient, these subjects could not express, not have some headache. So in this case, she was only the dizziness. She had no pulsatile tinnitus, but she had the clinical picture of the PPPD, and that's why I think the lumbar puncture and after that the treatment ameliorate all these symptoms. So it's about the precision of putting a diagnosis, and as you all too emphasized, when we know now that very well, us as otoneurologists or neurologists, that in case of minimal decompensation of the good labyrinthine function, in case of little asymmetry on the other side, we are focused on the side which is clinically speaking, it's symptomatic. So I think that many times we can um, forget that we must check the other side. So as the ophthalmologists, they know very well in case of problem on eye, they must try to compensate both sides in the same times. And because the an impairment of the vision on one side could generate some bilateral symptoms, and it's normal because we see stereo stereo mode, but we in a way which is a little bit very unexpected, because we know that the two labyrinths work together. We are focused on only one side, and we look not so very precisely on the other side. And I think that here is a problem which might lead to the diagnosis of a PPPD. And yes, of course, I do not think that PPPD is a diagnosis. This is a kind of refuge where we put some patients we don't understand
I really
the origin of
like
this
that.
blanket.
PPPD is a refuge. I really like that. I'm going to write that down.
Yes,
That's-
unfortunately,
that's-
there are some patients which are referred to us with PPPD, and they ask, "What is PPPD, doctor?" And
Yeah.
that's all.
Yeah.
But I think you get to the other issue that it's if they use the criteria the Barony Society has put out, you could respond by saying it's a dysfunction of your otoliths or your gravity sensors. But the problem is it's becoming a dumping ground for physicians to, oh, I've got this crazy dizzy patient, boom, they got PPD, send them out
Yeah.
and send them to the psychiatrist instead of actually trying to help the patient. That's the problem with labels. Once they get labeled something in our medical system, they've got that for the rest of their life.
Yeah.
And I have to admit, I try to stay away from labels as much as I can and be more descriptive in what a patient has because of that.
When the Barani Society came up with this, I remember being there were some fairly heated discussions about what to do, and a lot of the people wanted to initially include one of the P's as phobic. Well, we tried to explain that phobic is a really bad label because it means by definition you're psychiatric almost. So they got away from the phobic thing, but like you said, they still said, well, we've got to have something to call it. Let's put a label on it because patients need a label. Well, some people like we agree patients don't really need a label. Some people do feel that physicians need a label. But what do I tell this patient? I have to tell them something. So one other comment I had that second case of yours, Mohamed, that was really, really good. And I think that's a classic. The patient obviously had an acute attack 8 months beforehand or whenever it was, which almost destroyed her labyrinth. And now you found out if she has a good functioning labyrinth on the other side. Let's simplify things down. And I tell medical students and patients that it's just like an airplane engine. It's worse having her ice water calorics. That is so helpful. There's a little bit of function left. Having a little bit of function left is worse than having none. If you were the pilot of an airplane and you lost an engine, you can fly it on one engine. If you had a fluctuating engine, you can't, talk to the physiotherapist. You can't compensate for this because you don't have a steady state. So you go in and you wipe out the slight fun, which is exactly what you did, Mohamed. That is totally appropriate. Again, like Eugen said, as long as you know the other side is functioning appropriately.
Of course. Yeah.
I like the analogy of the airplane, Art. I'm going to use that one.
Yes.
Oh yeah, and it makes so. He said, "Oh yeah, I understand that." And I said, "I'm not a pilot, but I've talked to hundreds of pilots, and this is what they all say." So
yeah.
Awesome.
Yeah. I think the Barani Society over the past 10, 15 years, I joined the Barani Society in the early 80s, mid 80s. And I think in the last 15 years, give or take, the focus of the Morani Society has shifted quite a bit.
I agree. It has.
Yeah, and the current president, I don't know if he's an otologist or a general ENT. I'm not sure.
He's a
I know
neuro-otologist.
he's an E. He
Mikhail
must be
Carl.
an ENT.
Yeah.
He must be in
Work,
Uppsala.
yeah.
But
Works quite
whether
closely with Mons Magnusson.
Mons is otologist, but I don't
Yeah.
know if the
Mikhail
new.
Mikhail Karlborg. Yeah, he's an otologist.
Yeah. Okay. Which is good. So I think there has been a little bit of significant changes in the Barani. I'm no longer a member. I'm kind of, uh, uh, you know, seniors supposedly, but I think the Barani Society, it's a very good society, and it has a strong name, and what they say counts. Words count. But I think particularly that inclusion of PPPD, I don't know what was going on over there.
I agree with you. I think it's laudable what they've done to try and formalize diagnostic criteria for different vestibular disorders. In particular for PPPD, I'm happy that they got rid of the anxiety panic stuff out of it.
Yeah.
But I'd rather they had called it something different, like I said, otolithic dysfunction syndrome.
Uh, uh,
Uh, but it
what,
goes back again to, the point that um, Lauren Bartels made. That it's not a diagnosis, it's a syndrome, and
Yeah.
it's a syndrome of otolithic dysfunction, and
yes,
it can be caused by a lot of things, like in Mo's case with the acute, whether it's vestibular neuritis or whatever the heck caused it. The patient with the elevated intracranial pressure, the patient with the superior canal dehiscence, the guy with the venous outflow obstruction. I mean, there's a whole bunch of potential causes. And I think that's the one thing I would emphasize to my colleagues that, just because somebody presents like PPPD, that's not the end. It just tells you what their clinical
Something.
profile looks like.
Yeah.
yeah. Well, I mean, we go back even to BPPV, Jerry, and everybody else. We know that a lot of these patients are diagnosed with BPPV, even though they were not examined for it during the ENT exam or the otologic exam, and also during neurology exam. And that is of a major concern. And I remember raising that with the Morani Society, but there were no interest even to publicly discuss it.
Um,
What do you think, Gene?
yeah.
You're our European representative here.
Yes, I think that I expressed myself for this. Yes, it's a good thing for the some patients which try to understand that they suffer, but there are some colleagues which I saw some people which have PPPD, the symptoms, the syndrome, and we have no diagnosis till a moment when the explanation came. I think that if we didn't we didn't knew the superior semicircular canal dehiscence or other dehiscence like that now 30 years ago, uh, we can understand that this patient which had instabilities, they had no diagnosis. But I think that progressively, some of PPPD's patients will get their diagnosis, the real diagnosis.
Yeah.
I would be more comfortable saying probable vestibular dysfunction, unclear etiology, or something like that. Yes, you have a
Mm.
most likely a brain ear kind of situation, but we really need to do a little bit more about finding out and nail down the exact reason for it. But PPPD is just
Yeah.
The psychiatrists have these, and it's been a long time since I've studied psychiatry, but they've got these multiple layers of clinical di or axes, I think is the term they use. And I
Mm-hmm.
think that may be applicable to our field as well. For example, you can say someone has a Meniere syndrome, but they also have unilateral hearing loss, and they also have a unilateral horizontal canal dysfunction and a bilateral otolithic dysfunction and right-sided BPPD. So it's sort of like you should have a kind of like a syndromic diagnosis, a deficit diagnosis, because I think a lot of that goes into appropriate treatment of these folks.
Yes, agree.
So I see Bullets on here, who's are going to be presenting for our next conference. Do you have any comments on our PPPD free for all? You're muted, Bullet.
Our
Yes.
non-PPPD. It's our non-PPPD free-for-all.
So sorry, I was late today.
Sorry.
It happens in there. So um, that's a very interesting topic. And yes, here and there I use that diagnosis, unfortunately. And so to me, I mean, it will be more like a central integration. Of course, that's the one that I see on there. And about binary society, they are very strong though. I mean, I tried to send a couple things to there, and then they refuse it without even reading it. I mean, a couple are even they're very difficult to penetrate, but they're finding more power, I think, on that part. I mean, do you feel like they are going more in the uh, fields that not demonstrational, or more like becoming more uh, theory-wise? I mean, Mohammed, I mean, what do you think? Or
They're making it. It's very expensive. It's very expensive to go, and we've been trying over the years to encourage it, to make it less expensive, to encourage like new blood, trying to attract new blood. Maybe researchers who don't have the money to go, but they have been sort of resisting that. So I agree. They're very, very strong, and hopefully it'll expand into introducing new blood and inviting new blood with different thoughts.
Bill, is the PPPD included in I don't use the diagnostic codes because I don't
Yeah.
deal with insurance. Is it included in the American code?
In the
yes,
ICD-10?
I mean, I don't know. I mean, my medical records gives it when I put it there, but I don't know if they modify it from something else or not.
I see.
I can find it if you want to.
I bet you get something like undefined unilateral vestibular dysfunction or something like that. Some kind of vague thing is my suspicion. I tell you, I'm going to have to wrap things up.
Yes.
Are there any other questions before I close things out? If not, I just want to make a couple of announcements. One, since our last meeting, the entity VuMedi has picked up our YouTube website, and they're distributing to their 900,000 physician database. So we're gonna anybody that's on this they're gonna get a lot of airtime, if you would. And we're also being featured on their website. Next month is our discussion is going to happen on March 20th. And as I mentioned, Bulent is going to be presenting, or I think along with one of his residents or medical students, has got a case for us. And I don't know the topic yet, but we'll find that out and promote it.
It's not, I wasn't thinking to put the cases, but I can put cases. So we did last summer, we did some couple caloric test experiments with the students. And we're going to actually bring it up to refresh our memory about the velocity storage. How we
good.
ENT basis, and that will be awesome to hear Dr. Hamid's and Art's decisions. I mean, opinion about before we submit it further. So it's gonna be the first time he's working on it. I mean,
looking forward to it. Looking forward to it.
Good.
We're looking forward for the feedback, and we're gonna combine it with the different things. But I mean, so be nice to us, okay? Don't.
We will.
Okay.
Yeah.
Okay.
So be gentle, please. You know.
Okay.
My PhD was in modeling the caloric test response, so I'll be happy to
It is,
part of the discussion.
I know you guys are the experts, but to go nice with us. You know, we give some opinions, and if you find our sentences too strong, you just tell us, we modify it. But what we see, it really helped me to understand more in the perspective, although it was very simple test. I hope you guys will enjoy it too. And
I wonder how many times the word velocity storage appear on the ENT board exam or the neurology board exam.
No, I'm ENT. I don't understand. If the ENTs will say, no, I'm an ENT. I don't understand it. That's what they'll say.
Oh, Mohamed, we got a response for PPPD. It's the ICD.
Yeah, it's ICD 10.
Is H81.8X9. Other disorders of vestibular function unspecified, which kind of makes sense to me. One other thing I want to point out, guys, and I have screwed up on this multiple times. So I want to make sure I get it right. But my understanding is Europe is going to go through their time change by the time we meet again. And so instead of being 5 p.m. next time, it's going to be 4 p.m. Does that sound right, Eugen?
I think so. Yes, I will try to.
If it's not,
fix
please
my
let
clock.
me know.
I'm gonna be on European time in March, by the way.
There you go. There you go.
Yeah. Have a look at your phone and double check.
All right, guys. Well, it was another great meeting, and we look to visit again next month. And again, if anybody's got any comments or questions or even suggestions for future meetings, feel free to let us know.
Yeah.
Perfect.
Thank you all.
All right, guys.
Thank you.
Thank you, Jerry. Thank you, everybody. Good to see
enjoyed.
everybody.
See you.
See you.
Bye.
Bye-bye.